Yes,
So,
sir.
yeah, so Bismillahirrahmanirrahim. Today's journal club is about a topic that I guess may be common to a lot of us working in different fields: surgery, medicine, nephrology, cardiology, critical care, of course, and others. And the whole idea behind presenting this is to try and take us through a step-by-step approach to looking at some of these modern randomized controlled trials that we have and try and dissect it out into bite sizes, and then one should be able to actually decipher what the article is all about and make one's own conclusions rather than banking on conclusions and discussions that the authors put here. So the topic you are aware, and the this particular topic has been of interest to me for the last several years, and usually one gets into a situation where you come into an intensive care unit or a surgical ICU or emergency room, and there may always be more than one ways of doing things in terms of choice of IV fluids, and the main goal, of course, is resuscitation. So this was published in the New England Journal of Medicine just recently, about 3 weeks back, and it was done by the PLUS study investigators and the Australia New Zealand Intensive Care Society Clinical Trial Study Group, and it included a favorite critical care trained nephrologist or nephrology critical care person. I guess mostly critical care is his background. Not Ronaldo, something Belomo, and this Belomo has been publishing various things regarding ICU related acute kidney injury and CRRT for a long time. Had the pleasure of working with him, and in fact overlapping him in Pittsburgh over 2 decades back. So I know that when he publishes something, there's always good methodology behind it. So just moving right along. So the study question was, would balanced electrolyte solution compared with saline decrease 90-day mortality in critically ill patients? And obviously the authors want to look at that, but then one needs to go back into the article and see what is their null hypothesis and what is the alternate one. So the null hypothesis would be there is no difference in 90-day mortality between balanced electrolyte solutions and saline in critically ill patients. And the authors or the investigators' alternate hypothesis, which they want to show, is the balanced electrolyte solution compared with saline would decrease the 90-day mortality. And so when somebody says and puts their money on one-sided decrease or increase or better or less, rather than saying there's no difference, then it's when you want to show superiority, it's always a one-sided hypothesis, which is important to kind of keep in mind, because then your p-values become significant as 0.025 and not 0.05, which is the norm for a two-sided hypothesis. So that's the hypothesis. And what's the background? So we all understand that saline has a sodium and chloride content of 154 milliequivalents per liter each. And we've been using balanced solutions from times immemorial, since the days of Ringer's lactate and Hartmann's solution, and now Plasma Light and other commercially manufactured solutions, plus those which are initiated by an intensivist or nephrologist or a surgeon, depending on the patient's background. So balanced solutions more or less have a lower chloride content, so around what is there in the serum, maybe between 104 to 111 milliequivalents per liter. That's the only difference, and then the rest of it could be combination of bicarbonate or lactate, or as the case may be, as a buffer. So there have been studies in the past where solutions like 4% albumin, for instance, in traumatic brain injury, or hydroxyethyl starch have been shown to increase mortality in those subgroups that they were used in. And previously, some studies have suggested that saline may actually be harmful in critically ill adults. And this was in an open label, single center cluster crossover study from US, published in the New England Journal of Medicine 2018. Another one, which was published in JAMA before that, had not shown any difference between a buffered crystalloid solution versus saline in acute kidney injury development among patients in the ICU, which was a split randomized controlled trial, a double-blind cluster RCT. So the question was, would like in a head-to-head study, would balanced solutions actually decrease a hard clinical endpoint, which is the 90-day mortality, when used compared with saline? So if you look at the article, and that's what I've summarized for you, it was approved by, it is a study done over 53 centers, and each center's IRB approved the study. The sponsors, which were with this critical care study group, as well as the suppliers of the balanced solution, Baxter, had no input on the study design or its conduct, analysis, or reporting of outcomes, or publishing it. So it is actually, that's when you state that, you have to take it as face value that yes, that's exactly what it is, and no one has any influence. So sponsors have no way influence in reporting the outcomes. The informed consent was either written or oral consent, and of course, if the patients were critically ill, once they were in a position to either continue with the trial and they could give their own consent, or a legal representative gave the informed consent. The study design was an investigator-initiated parallel group. So obviously, when you look at randomized controlled trials, you can have multiple arms. This is a 1:1, 2-arm parallel group. It's not a crossover. It's not sequential. It's not any other factorial design. So there are several designs, as we all understand, in randomized controlled trials. It was double-blind and blinded at various levels, which we will look at. It was a randomized controlled trial across these 53 participating studies. So what were the inclusion criteria? So the inclusion criteria, if you look at these carefully, it more or less excludes a lot of people that we see in our daily practice. And that's what's important also to note about this particular study. So adults over 18 admitted to ICUs over a 3-year period. If expected ICU length of stay is at least 3 days, I think this is what we see mostly. But if considered equally eligible for either type of IV fluids, so in the eyes of the intensivist or the treating team, there were no specific indications to use one form or the other. For instance, if you ask me as a nephrologist, somebody has, requires volume, and we obviously, people usually with volume losses develop contraction alkalosis. So you give saline, and saline. And if somebody has upper GI vomiting and they develop metabolic alkalosis, saline again would be appropriate. But if somebody has diarrhea with lots of bicarbonate losses, then you may want to replace some of those bicarbonate losses with a balanced solution. So if somebody has severe metabolic acidemia and particularly renal insufficiency, then again, you may want to have a balanced solution. So there are different things that you would do when you know there's a particular indication. But in this case, if you knew that there was a specific indication, you would not include them. So they were considered eligible for either type of IV fluids, which was not specifically indicated. The exclusion criteria, so again, if eligible for a specific type of IV fluids, so if we knew that we wanted to use saline or a bicarb-based solution or Ringer's lactate or plasma light, then we would not include them in this study. They had already, if somebody had already received 500 ml plus of a resuscitation fluid before randomization, if the expected survival was less than 90 days, I mean, that's a tough one, because most critical ill patients, you want to know exactly, it's very difficult to predict that, but of course there are predicting analytics such as SOFA score and Apache 2 scores. So maybe that was what they based it on. And if they had a high risk of death, they were also excluded, and traumatic brain injury or risk of cerebral brain edema, they were also excluded. So the primary outcome measure for which the sample size is calculated was death from any cause within 90 days of randomization. And the secondary outcome measures included a lot of renal outcomes like the peak serum creatinine within 7 days, a maximum increase in creatinine during ICU stay, need for new renal replacement therapy, use of vasoactive drugs, days on mechanical ventilation, length of stay in ICU, and death from any cause within 28 days, either in the ICU or during hospitalization. And there were some pre-specified subgroup analyses of the primary outcome, including based on disease severity scores, sepsis, acute kidney injury, age, sex, and ICU admission after surgery. So the randomization was done through a central web-based system with permuted blocks of variable sizes. So the blocks could be 4, 6, 6, 4, or multiples of 4, 4, 8, 4. These are done so that you do not, it's a form of randomization where you conceal the allocation sequence. And it was also stratified according to the ICUs, and the allocation was also concealed through use of 1000 milliliter identical looking bags with obviously the same weight of the two solutions, and which looked similar, and you couldn't tell which one had what. The blinding was done at the level of the patients and researchers, the treating clinicians, as well as the legal representatives. So the blinding was done on multiple levels, and that's what was also clearly stated. So if you look at the data that they were going with, then just a sec. So if you look at the data from day 1 to 7 that they were collecting, and from days 8 to 90, baseline demographics obviously were done, and in addition to that, Apache's 2 score and SOFA scores were done between days 1 and 7, along with hemodynamics and ventilatory support related data, organ support, whether on dialysis or CRRT, fluids, blood products, and volume administered, and of course the urine volume and daily chemistries. From days 8 to 90, one would also still continue to collect data on whether they were still requiring any form of ventilation and renal replacement therapy, the creatinines, and the volume of trial fluids administered till day 90, which was the trial endpoint. So the sample size was estimated. So they assumed a baseline mortality for these patients of around 23%. And just to put that into perspective, in general, patients coming into a medical ICU, especially with acute kidney injury, they still continue to have around 50 to 60% mortality. If they have acute kidney injury in a surgical ICU, it may go up to 70 to 80%. And in a burn ICU, it may go up to 90%. That's with acute kidney injury. So these obviously, this was on all comers, an average baseline mortality of 23% was assumed for these patients who required resuscitation. And they figured that an absolute risk reduction of around 2.9% in 90-day mortality would give them an estimated sample size of 8,800 patients with a power of 90% to detect a difference. However, in December 2020, because of COVID issues and ongoing funding issues, they decided to, blinded to the trial data, they decided to recalculate the sample size and used an effect size of a 3.8% reduction in mortality, but used the same 90% power, and they were able to probably end this trial, at 5,000 patients recruitment. And they were blinded to the results, obviously, at that point also. So the statistical analysis were, so you, as randomized, you analyze, so that's the intention to treat analysis. They did logistic regression for primary outcome of 90-day mortality to determine the predictors of that. In addition to that, they did adjusted analysis for covariates such as sex, Apache 2 scores, sepsis, and source of ICU admission. And they use odds ratios with 95% confidence interval and converted them to adjusted risk differences. Secondary analysis also included imputation. So for primary analysis, they did not do missing data imputation, which means that if you have data which is missing, so you basically either use an average score, so that's mean imputation, or you use a worst case scenario or a best case scenario, or you take a last observation which was before the missing data, you carry it forward. So there are various ways of accounting for missing data, which is extremely important in a trial design. So they did that in their secondary analysis and used a worst best and best worst reverse assignment of outcomes to either group. So if they had obviously they wanted to show that balanced electrolytes were better than saline, but then if the data was missing in the balanced electrolyte group, they would assume that patients would actually have a high, would actually die within the 90 days. So you use the worst outcome. And similarly, if data was missing in the saline group, they would also use the worst outcome so that to avoid any bias. So they wouldn't use even an average outcome, they would use the worst scenario. Then they did various forms of sensitivity analyses accounting for fluids administered before randomization and the type of fluids and the volume administered. And then they also did a survival analysis with Cox proportional hazards, looking at the proportionate contribution of various aspects to the mortality. This O'Brien Fleming is one of several methods, including there's another one called PITO and whatever. So these are various ways of looking at alpha spending, which is your type 1 error, so to speak, and in your false positive rate. So in that the number of times you do analyses, you have to make some adjustments based on either an O Fleming or whatever. So I don't want to confuse you with those methods. And the Independent Data Safety Monitoring Board also did one interim analysis when a third of the patients were recruited, obviously for safety and futility reasons. So what were the results? So let's take you through the results here. And if you go through these tables with me, so let me remove myself. I don't want to see myself. Just a sec. Yeah. So can you still see me? Can you still see the? Can you see the full table?
Yes, we can.
Okay, thanks. So, so if you look at the baseline characteristics, this is the balanced electrolyte solution. This is a saline group. So more or less the age is similar. The mean Apache 2 scores were similar. The creatinine levels were similar. And also in terms of various types, whether it is mechanical ventilation or renal replacement therapy, if you just eyeball the figures, you don't need a p-value to show that they were similar. You can just see that they were all very, very similar, which is obviously the strength of the randomization. That's what prevents the selection bias. So obviously very well randomized across these 53 centers. If you look at this particular figure, every time, whatever criteria you look at in terms of trial days and the number of patients who were randomized to whatever group, then you would find that, just a sec, I need to mute this, I'm sorry. I'll take a half a minute timeout. 3 minutes, not 3 minutes. Pardon me. So after that strategic timeout, just getting back to what we were discussing, in every form of comparison between the saline group and the balanced solution in terms of the volume administered at various days from day 1 to 7, or in terms of separately looking at separately looking at crystalloids received in each group, there was no difference administered in both the groups. If you look at the arterial blood pH, obviously the saline group, because you have more chloride in it, you get a little bit of dilution acidemia. It tended to be a little lower compared with the balanced group. If you look at the serum chloride level, obviously in the saline group, because it has about 154 milliequivalents of chloride as opposed to 110 here, there will be higher chloride levels within the saline group. If you look at the serum creatinine, however, and all these confidence intervals overlapping each other, you find that there is no difference in the serum creatinines measured across these initial 7 days as well as subsequently. When you look at the trial outcomes and look at odds ratios and the absolute difference, you find that in terms of death from any cause within 90 days after randomization, you'll find that the odds ratios, even if you eyeball this, 21.8 versus 22%, the odds ratios being 0.99 with them crossing the point of 1, which is no difference, you find that the confidence intervals are always crossing 1 in this particular thing. Similarly, whether it is looking at mortality data or whether it is looking at any specific binary outcome, including new renal replacement therapy or vasoactive drugs, you find that there's no difference in the two groups. So there's no real difference in any of the hard clinical outcomes or the secondary outcomes, whether in terms of mortality or in terms of acute kidney injury, need for renal replacement therapy, or vasoactive, if you used either of the two solutions. And if you look at the Kaplan-Meier survival curve, you can see that they are pretty much overlapped throughout between the saline and the balanced electrolyte group. Again, the odds ratio being 0.99 and crossing 1 on either side. So there's no difference between the two groups. Now, if you look at the subgroup analysis of death from any cause, also one being, the point of no difference, and this side being balanced solution better, this side being saline better, you can clearly see that all these outcomes with the weighted average are all crossing the point of no difference. So again, in terms of all these odds ratios as well, you'll find that all of them cross the point of no difference, which is 1 on either side, as you can see as I take you along this. And so even with the pre-specified subgroup analysis related to age, related to gender, related to whether presence or absence of kidney injury, sepsis, admitted from surgery, Apache 2 score, there's no difference whether you used a balanced electrolyte solution versus saline. So if I just take you through a little bit of my own personal critique of this particular randomized controlled trial, this is an important negative trial, and it's extremely important to keep publishing negative results, because again, these are very expensive ventures, and before somebody tries to replicate it, if there's a good methodology and there's a negative result, then most people would probably accept that. And a lot of times there's a publication bias and journals don't publish negative results. So it was an important negative result and a clinical question that was answered. In terms of the validity, which is the internal validity, the randomization was done through these permuted blocks, allocation was concealed, blinding was done at multiple levels, power was 90%, so it was very strong internal validity. So what is internal validity is basically the integrity of the study design, and if that is good, then things can be externally valid or generalizable. So if it's not internally generalized and valid, then it's not externally generalizable. So it was very well done, very well conducted. The adaptive design was necessitated by the COVID-related uncertainties, but again, the sample size was recalculated with a 90% power. So if you missed any differences because of a type 2 false negative error, that would be very few with the number that they achieved with this sample size recalculation. It was an intention to treat analysis, so as randomized as analyzed. So again, in terms of outcome analysis and detection of outcome, again, when you have despite any patients dropping out of any group or crossing over to the other side or receiving the other kind of fluid, they continue to be analyzed in the same group they were randomized to. So that was again a very important aspect of analysis and internal validity. They did covariate adjusted analysis for all the confounders. So they did adjusted analysis using those confounders in both groups. So that's an extremely important aspect, again, to prevent analytical biases. The subgroup analysis was done not as a fishing expedition, but they were all pre-specified before the trial. There were individual sensitivity analyses removing one particular aspect and continuing to analyze the rest of the data to see if the overall outcome changes in any direction or not. That's a very strong method that they used. The interim analysis, obviously for safety reasons, was done by an independent data safety monitoring board, and you need to account for some alpha spending when you do that as well. And the survival analysis was done with both the Kaplan-Meier, the workhorse, as well as Cox proportional hazards, and logistic regression for primary outcome measures, and the missing data were also imputed. So if you look at this, a very well conducted study. However, when you look at the external generalizability, so as I pointed out earlier on, that yes, internally very valid and generalizable to the population, that you do not have a specific bias for in terms of the fluid you choose. So most of the time when an intensivist sees a patient or a surgeon sees a patient, OBGYN or anybody else, or a poor nephrologist myself, we usually go by the clinical scenario as well as look at aspects of acidemia or alkalemia or the underlying content of fluids loss and try and replace that. So when you have a specific indication for a particular fluid, we would continue to use that, because this trial excluded those patients. It only included patients when there was no particular reason to use one over the other. So there you can see that that's where a lot of the external generalizability to daily practice gets lost. The confounders were adjusted, like I said, with and even the co-interventions. So if they needed to give any antibiotics, they would also use the same co-interventions in both groups, like based in dextrose. So it's important also not just to look at confounders being balanced as a result of randomization, but even the co-interventions, one needs to be careful in making sure that no bias in terms of outcome comes in any particular group, because you had a difference in the co-administered drugs, and the solutions that they were administered in were also balanced in the two groups. So in terms of bias, I would say that selection bias is minimal, the detection bias was minimal, the ascertainment bias was minimal, the analytical bias was minimal. There was obviously no publication bias and reporting bias. So all these negative results were published by a good journal. In the analysis, they use intention to treat analysis. All those things were there. But again, when I talk about the external generalizability here, that's one particular thing where applicability to practice comes in play. So subsequently, so they have the authors in the discussion have put in a report of a new systematic review, which also includes this particular article. And when I looked at that systematic review, it's also on my desktop, but I don't want to show it to you right now. It seemed like there was a tendency towards some improvement in the balanced electrolyte solution in terms of outcome, but may have been clinically significant, but even though it was not statistically significant. So again, in that I saw that the confidence intervals were crossing one in particular direction, but were heavily favored towards a little bit of benefit towards balanced electrolyte solution in the other, on the other side. So this aspect will continue to be there, where there will be always a little bit of a biased thinking that perhaps are we causing more acute kidney injury by using saline? Are we causing an increase in mortality but by just using saline in a case where either solution could have been used? and would it be appropriate to use balanced electrolyte solutions even in that case. I mean, I particularly in my practice, I know that when you look at normal saline administration, if you give a lot of it, obviously you get dilutional acidemia, and frequently you'd find that one would then have to make some adjustments in terms of what one uses. So a lot of times one would begin looking at the acid-base equation balance, looking at the serum bicarbonate level, and try and account for that from the beginning. But these are cases, remember, where if you knew specifically what fluid to give, you excluded them from the study. So I'm going to end right here and take any questions, and thank you for your attention. Any questions?
Thank you very much, Dr. Quadri. I think, as you said yourself, this is something, a debate which is going on for too long, and every now and then you have something of this nature which actually potentiates the belief that there is not a lot of difference between the two, with perhaps some outliers thinking that the balanced electrolyte solution is better than the normal saline. Now, this is practically, this article is referring to the critically ill patients in ICU. Now, what about the patients say presenting in emergency department with acute gastroenteritis and things like that? So, do you think that is there any value of thinking about balanced electrolyte solutions superiority over normal saline in those cases as well?
Yes, I mean, so again, when you look at the exclusion criteria in this condition as well, those where you would have a specific indication for using a certain type of fluid. So if you have patients coming into the emergency room with diarrhea, and it is all diarrhea related to bicarbonate losses, then obviously you would want to use solutions which probably have a little bit of bicarbonate, expecting a anion gap metabolic acidosis. You may want to do that. If a patient comes into the emergency room simply with hypovolemic shock, then obviously as a volume expander, depending on what the hypovolemia is from, you would want to use saline. But subsequently, any acid-base derangements or presence of lactic acidemia or presence of metabolic acidemia, presence of DKA, all those things would drive the kind of fluid one uses. So whenever you as an ER physician look at a patient and coming with a particular background of either trauma or blood loss or burns or fractured hip, whatever it is, I mean, whatever solutions you think that are appropriate at that time should be used. That is not where you would say that, okay, I don't care, just hang either balanced solution or hang saline. I think it should be directed by what your best judgment is at that point, recognizing that there are limits when you have severe sepsis and severe septic shock and lactic acidemia. Even there, a lot of people find use of bicarbonate controversial. So, because that may actually increase intracellular acidemia and may actually cause a differential between the brain acidosis as well as the peripheral blood acidosis or acidemia. So you use your judgment. If you feel that there's a lot of blood loss, obviously you're going to use blood products. If you feel that there's burns and all that, you use albumin or plasma or any other thing that you think is appropriate as a colloid. If it's a liver cirrhosis patient, third spacing, you may want to use albumin. If it's somebody who has acute kidney injury with hypovolemia and has acidemia and creatinine is 3 or 4, then you may consider using a bicarbonate-based solution. So I would say that, again, the same thing would apply, that in terms of generalizability, when you know that there's a particular indication of some benefit, there's a upper GI vomit and you use a bicarbonate-based solution. But if there's a lower GI vomit where you lose your bicarbonate from lower intestinal obstruction, for instance, you may use more saline-based fluids. But if it's an upper GI vomit where you lose more of your chloride, then you may use a bicarbonate-based fluid. So just using the pathophysiology, best intuition, I think that's the best practice. continues to be the best practice. Thank you. Thank you for asking the question.
Thank you.
Any other comment or questions related to the study design or to some of the aspect or to the design at the back to the brick wall that I have here?
So Dr. Mujtaba, I have a question. It's related to the study, so whenever we see a lot of these randomized trials, they do randomize or mention about, the race of the patient, like a lot of these treatment effects also vary, like, African American versus Hispanics versus Asian. And sometimes in your clinical practice, like, looking people of like Southeast Asian, sometimes we do see the treatment effect and the doses are different. I don't know if the study mentioned about anything related to the race or, of this, and how would you use that information to change your clinical practice in Pakistan?
Well, I think you got me on that one. I believe, because they're all Australia and New Zealand population, it may be mostly endogenous population, but they obviously have a lot of immigrant population in there. But I can go back to the article. I'll have to go and share screen again. Just a sec. If I can do that, I can.
I tried to look. I didn't find.
Possibly it was not there in the demographics. I guess if I did share that, so maybe yeah. I mean, like if you consider race as an important factor in fluid resuscitation, perhaps that is a genuine concern. I mean, like if you look at practices worldwide in ICUs or in the ER, in terms of choice of solutions, even in the norm, people don't look at whether somebody is an African American or black or white race, whether a particular choice of fluid would be beneficial in that population. Patients come in and it's their volume status and their various forms of resuscitation requirements based on their disease severity of illness that usually directs what kind of fluids you use. So I'm not sure if race would be an important component in this, but yes, if you were looking at medications which are metabolized by the liver and you have different backgrounds of people in terms of their pharmacogenomics and in terms of genetic polymorphisms that they exhibit, then people would metabolize things differently. But when you look at saline stays entirely in the extracellular compartment. And if you look at a balanced electrolyte solution, that also stays almost entirely in the extracellular compartment and gets distributed into the blood volume or the plasma volume. So I'm not sure if that would actually impact upon how a different race would respond to different kinds of fluids. So, I mean, like mostly if you look at the biological plausibility, when you look at drugs administered, yes, I mean, I think you can consider saline and electrolyte solution as a drug also, but these, because they predominantly stay and do not go through the first pass metabolism, do not get absorbed and go into the enterohepatic circulation and all, I wouldn't expect a whole lot of difference between races. But yeah, I mean, like one could look into that. Dr. Sajjad, you have a question?
Yes, Dr. Quadri, thank you very much for giving such a detailed and nice presentation on a very difficult topic. Just being a clinical sort of a student for many years, I still, I've got that confusion which fluid to use. If you go over the last 2 decades, there has been debates about crystallites and colloids, normal saline not being a normal saline, and different discussions going in the papers, and now this discussion about the saline and the balanced electrolyte solution. Do you feel, as a and sort of being a teacher in the research and studying all these papers, do you think there's a time now to change the current guidelines, which we are, say, dealing with the DKA, or which, dealing, as Dr. Vahid said, with the resuscitation of critically ill patients in emergencies? Or should I phrase my question in a different way? Do we have any meta-analysis, sort of a systemic review, to clarify this confusion which we have as a clinicians?
Yeah, I mean, like I mentioned, that a very recent publication has come out where they have come up with a systematic review, and if I can just quickly show it, it might just be on my desktop. I might just be able to show it to you. I think I had downloaded it as well. Just a sec. Is it here? I'll find it. Is it here? The systematic review. Systematic review. No, I don't see it here. I thought I had downloaded it. So just to, can you still hear me? Yeah. So just to reiterate, this systematic review actually included this current study, which was a very large randomized controlled trial, and tried to give the impression that the author's impression that they tend to favor the balanced electrolyte solutions when there is no specific reason to use a particular solution. But even there, when I looked at the data, the confidence intervals crossed the 0.1. So that was a case of a perhaps a little bit of a clinical significance, but not statistical significance. So the question remains unanswered. But with that systematic review, when they actually included this particular trial, like it says in the discussion, and I actually looked at the original systematic review, I found that I couldn't remove the bias of the authors from what this conclusion is. So even there, statistically, they could not show that balanced solution is superior, although clinically, they tended to talk about some posterior assumptions and said that posterior probabilities suggest that balanced solutions may have a role when you don't have a specific choice. So I would say that these guidelines will keep coming. This was as good a randomized control trial as you can get a hold of. And a lot of times systematic reviews also, when they don't get a good answer, they say, oh, a proper randomized controlled trial may answer this question. So these guys, in their methodology, even though they were forced to do sample size recalculation, and but even when the data was collected for 5,000 patients as opposed to the original 8,800, they did what was known as a futility analysis and fragility analysis. These are ways of detecting whether if you switched over the outcomes to the other group, would it make any difference, or if you had recruited some more, would it have make any difference. But the point of futility of the study was attained before 67%. So they recruited eventually 5,500 patients, but originally were intended 8,800, and that futility point had been reached in the interim analysis also. So they, even though yes, you didn't achieve the original 8,800 things, but they did not change the effect size or mortality reduction any more than 2.9% to 3.9%. So even with doing that, they could not show that there was any tendency towards betterment in either group. So from my point of view, if you want a simple answer, when you know what fluids to use based on your acid-base status and based on the estimate of what fluids have been lost, blood or plasma, or whether you're dealing with burns or you're dealing with hypovolemic hemorrhagic shock, for instance. So you know exactly what fluids need to be replaced, the ones which got lost. So similarly with diarrhea, you know, it's bicarb based, but if you have chloride diarrhea, then it has to be chloride based fluids. If you have vomiting from upper GI, it should be saline based resuscitation. Vomiting from lower GI, it could be, vomiting from upper GI, it's bicarbonate based replacement, and vice versa for vomiting from lower GI sources when you have metabolic acidosis as a result of bicarb loss. So when you know of a definitive indication, they also excluded that. See, so that is why when you look at the study design, although it's a negative study, I would say that the ones that we see commonly where we use our clinical judgment to use fluids were excluded from this study. Any other questions or comment? Thank you for that comment. Made me think. So if that is it, thank you. And thank you for being with us today. And I'm happy to answer any questions subsequently, inshallah. Take care. Assalamu alaikum.